Hello, I'm Tim Davis, Telehealth Manager at Oklahoma State University Center for Health Sciences in the Center for Rural Health. I'm also the Executive Director of the Telehealth Alliance of Oklahoma, which is a nonprofit telehealth advocacy group, and I'm the Oklahoma representative for Heartland Telehealth Resource Center, which is a HRSA-funded Missouri, Oklahoma, Kansas, again, telehealth resource and education center. So we'll just kind of go over an introduction to telemedicine and telehealth. There's a lot of information, so really this is just kind of be some hitting on the topics, the high points of things. So disclosures, I do not have any relevant relationships to disclose, so that was pretty easy. Learning outcomes. So what we'll kind of go over and hope to get out of this are some definitions and types of telehealth and telemedicine. Talk about some of the different technology used in telemedicine, best practices, issues with the current system, and implementation keys if you do want to go ahead and implement a telemedicine or telehealth practice. So if you would, just kind of try to imagine, what healthcare could look like if clinical care is available anytime and anywhere. Clinicians could obtain consultations with medical centers of excellence, again, anytime, anywhere. Medical education programs are available. Homebound patients could be monitored remotely, again, anytime and anywhere, not just your typical 8 to 5 Monday through Friday. This is really what telehealth has the potential to bring. It has the potential to dramatically increase access to health care and also importantly, healthcare information. So we'll just kind of start out with some definitions. Telemedicine and telehealth, a lot of people think really that's kind of an interchangeable term, but there are some specific differences. So just got the definitions off of Medicaid.gov, where telemedicine is defined as a two-way real-time interactive communication between the patient and the physician or practitioner at the distant site. This electronic communication means the use of interactive telecommunication equipment, at a minimum includes audio and video equipment. So it's not just a phone call, audio only. It does need to be audio and video. Telehealth is the use of telecommunications and information technology to provide access to health assessments, diagnosis, intervention, consultation, supervision, and information across a distance. So really telehealth is a broader scope of remote healthcare services, or again, telemedicine is technically a subset of telehealth. Telehealth differs from telemedicine in that it encompasses a broader scope of remote healthcare services. Telemedicine refers specifically to remote clinical services, but telehealth can also include remote non-clinical services such as provider training, administrative meetings, continuing medical education, etc. So a lot of people end up kind of using those terms interchangeably, and I think for the most part it's acceptable, but just know that there is an actual technical difference there. This is one which it's kind of, for me, I find I get these kind of switch back and forth, so I thought it's important to get these definitions in there as well. The difference between a distant site and an originating site. So a distant site, that is where the doctor is. An originating site is where the patient is. So an originating site is CMS authorized types of provider. Originating sites include like a physician practitioner's office, hospitals, critical access hospitals, federally qualified healthcare centers, rural health clinics, skilled nursing facilities, community mental health care centers, etc. So not just anywhere can be an originating site. The distant site where the provider is, that really is much more open. Again, as long as the provider is just practicing, the patient is in the state that they're licensed to practice. So what are really some types of telemedicine and telehealth? And really there are four main types. You have your synchronous or live interactive, asynchronous, which is store and forward, remote patient monitoring, and mobile health or M-health, which is relatively new. So for synchronous or live interactive, that's where a patient and provider are communicating two-way in a real-time video conferencing system. So it's just like going into a physician's office, except which is live, except you are in your location and the physician is in another, and you're doing it via video. It does allow providers to assess patients using medical scopes or equipment live. So again, with technology and Bluetooth technology, a physician can be here in Tulsa, might have a patient in Muskogee or Podo, and that have equipment there in Podo, and the nurse is able to use those scopes or equipment on the patient, and the physician or provider back in Tulsa would be able to see, hear, use those scopes as if they were there in the same room. This is good for primary care along with specialty care. Also good for patient education. Again, you're live. There's that one-on-one, that feedback. There's the anticipating of questions and being able to get their response and follow up. Also very good for support groups because, again, it is live. You can have that interaction. The second type is asynchronous or store and forward. This is electronic transmission of a recorded health history to a clinician, usually a specialist. For example, demographic data, medical history, lab reports, image, video, sound files, etc. We would use this when a face-to-face visit is not necessary. For example, maybe a radiology review, maybe getting a second opinion on a derm consult, etc. Picture and history are adequate for diagnosis. So again, the specialist is able to diagnose based off of the picture and history of the patient and not needing to have them live in the room. Participants can be located anywhere without the need for travel. So again, the patient can be in their home or their local area and not have to travel. Second opinions are quick and easy to obtain. This may be where you may have a primary care or a specialist, and they're just not sure about something and they want to get a second opinion. They can afford to send this information, the data, the pictures, etc., on and get a second opinion quickly. It does allow the clinicians to do work when convenient for them as well. So maybe the clinician has time throughout their day, holes kind of in their schedule, and during that time they can stay busy by reviewing asynchronous data and patient records. So in that regard, it does maximize the use of a clinician time. If there is an hour or 2 hour break with no patients in that day, the physician's able to stay busy. The third type, remote patient monitoring. And this is the use of connected electronic tools to record or capture personal health and medical data in one location, like your home, for review by a provider in another location, usually at a different time. So there really, with remote patient monitoring, is an opportunity to extend care between and beyond hospitals and really go into the patient's home. When a patient is at home, of course, they're typically more comfortable. You may get more accurate readings on maybe your pulse ox or even your respiration rate or breathing rate, weight, things like that. They have a lot of really neat tools. I mean, there's a tetherless sensor, pulse ox, blood sugar, wellness checks. All these are able to be used on the remote patient monitoring. There's also some decision-making algorithms, and they're there really to provide early warnings for proactive care and continuous pragmatic improvement. So maybe you have a patient who is kind of logging or charting some daily checks or parameters. Maybe it's blood sugar, and they do that twice a day, and it's captured. And once it hits, the algorithm sees it. Maybe it's trending up too high. Then we can do some kind of a reach out or send some kind of a targeted message to the patient to let them know how things are going, and maybe we need to kind of reevaluate things. The University of Kentucky healthcare system has recently implemented a tele-ICU clinical command center, and this enables intensivist and critical care nurses to remotely manage ICU patients, allowing their teams to prevent crisis rather than merely responding to them. So what we found is the tele-ICU and remote monitoring, you're able to actually monitor more patients and actually more effectively than necessarily just being in one-on-one, going into the rooms, et cetera. So hopefully we can kind of see and or catch things before it gets to a point, cut it off at the pass, so to speak. Triage and monitoring of COVID-19 patients, again, that's, very important with it being the disease that it is, a lot of, based on temperature, respiration rate, oxygen saturation. If you had a PCP, the patient, they thought they might have that or did have it and be sent home, they can continue to remotely monitor those symptoms and parameters safely versus having to come in and potentially infect, everyone in the office. Mobile health or mHealth. Again, this is healthcare and public health information provided through mobile devices such as cell phones, tablets, laptops, etc. Information can range from targeted text messages that promote healthy behavior to wide-scale alerts about disease outbreaks, etc. So again, something that's really become more popular over the last 5 to 6 years with the targeted messages. So some examples of telemedicine and telehealth. On your left there, the telemedicine, teledentistry, telepharmacy, telebehavioral, any of the clinical functions that would happen in person would be really a telemedicine type of an example. A mobile clinic, which we'll go over here shortly, where we're actually going out into maybe a rural or an underserved location and providing clinical services there. Online consults with specialists, again, primary care physician maybe needs to get a consult from a dermatologist. They can do that easily. School-based telemedicine as well, where you're actually taking a physician and nurse into a school via video conferencing system. And on the right, some examples of telehealth. Like we kind of talked about, the remote patient monitoring. Again, these are not necessarily, they're clinical, but they're not the clinical necessarily needed to be by a physician. Kiosk for patient education, provider education, didactics, Project Echo, like we have here at Oklahoma State, where you have specialists providing kind of a case study to primary care physicians. OT, PT, speech and hearing, grand rounds, etc. All of these are various types of telehealth. So here we have a kind of what is a picture of our mobile telemedicine clinic we have at Oklahoma State University Center for Health Sciences. We take this, it's been all across the state. We've done, again, some mobile clinics in rural locations. Right now, we do take it to 2 different rural locations and do some HIV/AIDS clinic work with Dr. Ladd here in the IMSS clinic at OSU. So the bus is fully outfitted inside with everything needed as a clinical room. It does have a video conferencing system. We have the different scopes and cameras needed on board. We have a location where you can do some screening before the patient would get back and see the physician. We also use it for taking it around to do just some, again, mobile clinics, some kind of touch a truck. We take it to fun runs, local, et cetera, to be the local clinic. It is disaster response ready as well, fully outfitted with the various phones and two-way communication, so that if we had a major disaster here in Oklahoma, we could take that out and set that up as either a mobile command center or a mobile clinical area. So the need for telehealth. Why do we need telehealth? Why is it becoming what it is? Why is it kind of up on everyone's radar in 2020? So really, one of the many reasons, clinical shortage areas. So you're definitely going to have certain areas, whether it's because it's rural or just there's not that many of that type of clinicians in the area, but the shortages. So if you don't have a specific clinician or specialist in your area, again, to save from the time and cost of travel with telehealth, you can stay in your particular area and see those specialists. Rural and urban underserved. Again, with the advent of this technology, why do I need to drive 3 hours to see spend 15 minutes with a physician when I can stay in my area, maybe take only my hour for lunch and be able to see a specialist out of the area. An aging population. As we, of course, age, maybe we're not driving as much or don't feel comfortable driving in certain weather or after dark. So this way they can stay again in their local, maybe with their local physician or primary care doc that they're comfortable with, but yet still see that specialist that they need to via telemedicine. Travel, time, cost, and hardship. We kind of already touched on these, but I know in some of the rural communities we take the bus with, some of these folks are working in organizations that if they had to take off an entire day to go see a specialist, in Tulsa 3 hours away, that's a full day off work, which maybe they don't have to take off, or it really causes a hardship with childcare, arranging that with time off work, the cost of losing the money for your work, and then also for gas and wear and tear in your vehicle. Language barriers. This is a good one as well. So we worked with another clinic where they had a high Spanish-speaking population, and they had a translator, and that translator would go to the various remote clinics to translate. Unfortunately, that was spread out over a couple hundred miles. So this translator would only be able to see maybe a few patients a day or 3 patients a day with the driving necessary in between. Whereas if we use telehealth, that translator is able to be on, they can stay in their location, the patient's in their remote location, and the physician is in theirs, and they're able to see patients back to back to back without that translator having to move around to the location for each patient. And then, of course, what we're in right now, a pandemic. With what we're going through now, everyone's kind of working from home, telecommuting for months at a time, but yet we still have a need to see a physician. Telemedicine has really stepped up and filled a lot of those needs. And I talked about the cost. I know I found a report from 2018 by the Kaiser Family Foundation using the CDC's behavioral risk factor surveillance system. From 2013 to 2017, Oklahoma had approximately 16% of its population report not seeing a physician due to cost. Now, of course, some of this is cost of office visit, et cetera, but a lot of this cost was also, again, from the travel time, the gas time, the taking off work time, et cetera. So 16% of a population of Oklahoma, that's, again, roughly 600,000 Oklahomans that either put off or did not seek medical care because of cost. So this is a summary, a 2020 telehealth summary that the Oklahoma Healthcare Authority completed, and it looked at March to June 2020 and compared it to the same time frame of March through June of 2019. And I just thought it was interesting if you look at some of these numbers of how much telemedicine, telehealth has grown and is being used. Of course, a lot of this was, I won't say forced, but it was implemented due to COVID, but I do think a lot of this will stick around. But one of the ones that popped out is the second line there on the left. How many providers conducted services via telehealth? So last year it was 208 providers. And this year, that 3 month or that time span of March through June, 1,815. So a dramatic increase in the number of providers. How many telehealth visits were conducted? Again, 2019. Roughly 12,000, whereas in 2020, 337,000. So just a huge jump in telehealth visits. What was the average number of telehealth visits per member utilizing this service? So before, 1.7. So each member might use this just over 1 to 2 times for a telehealth visit. versus if you go to March, that's 4.3. So you have not only more individuals using telehealth, but you have the ones that are using it more often. What was the average reimbursement per member? So again, prior in 2019, it was $140. In June or of 2020, I'm sorry, it's $307. So now a lot of this, it may be a little misleading. A lot of this, of course, is due to with the CARES Act and then relaxing some of the payment parity issues. That certainly hasn't, driven up the reimbursement per member. And if you look over on the right side, just some interesting information about what the telehealth services were 2019 versus 2020. Some similar. The alcohol and drug went from number 2 last year to the top now. Office outpatient visits, went from number 1 in 2019 to number 3. But those are still there. What's interesting is the total unique procedure codes used was 44 in 2019 versus 172 in 2020, which would mean that they're using it for a wider range of uses. So that's great. And then at the bottom, what was the telehealth utilization in rural versus urban markets and per capita? So if you look in that middle there, the percent members served by county type, 38% are rural, 59% are urban. So it's interesting. I know a lot of people kind of really sell telehealth as being for rural only. But if you look, actually the urban setting is using telehealth more. Now, again, if this is from 2020, that certainly could be influenced by COVID-19 and being, needing to stay home and not having to go in to see a physician or a provider. But just very interesting that the urban is still very much higher than the rural. So what are some telehealth benefits? Some of them, increased access or reduced barriers to care and to a specialist. So again, I grew up in a small town in Oklahoma, and we didn't have a specialist. So you basically went to your primary care, and if it was something that was beyond their scope or they didn't feel comfortable with, you were sent to Tulsa area to see a specialist. So with telehealth, nowadays I could have stayed there with my local PCP and then just seen the specialist with him. Collaboration among healthcare professionals. So again, with Project Echo and all the different education that's available now, you have those primary care or those other even specialists out in the remote areas able to collaborate with other professionals to get second opinions or just to have greater educational opportunities. Improved decision making. Again, so much more out there. It's education and information that's available to the provider. It's able to help them with their decision making. Education, we kind of talked about that, not only from a provider standpoint, but from a patient standpoint as well. With telehealth, there's so much education out there, or education that can be provided to the patient that just really was not available, or maybe you were sent home with just a pamphlet prior to telehealth. And it can certainly lower the cost of healthcare as well as increase patient satisfaction. I think there's definitely an increase in patient satisfaction from the standpoint of right now usually there's a decrease in wait times, and with the technology we have, it's very, very much very similar to being a face-to-face visit. So we kind of talked about that decreased wait time and provider location options. So kind of like the funny little cartoon there on the right. I'm a stay-at-home teleradiologist. He's not used to wearing, pants, and he's wearing his slippers because he's used to working from home. So, the provider can be, they could be not necessarily just at their clinic site. They can be wherever they need to be, as long as they're practicing, of course, in the appropriate state. Excuse me. Best practices, or what we're calling website manners. So, these are things that we need to pay attention to and keep in mind when we are doing a telemedicine visit. So it is very much medicine, You are still face-to-face with a patient and interacting, but there are some things we need to make sure we look out for. So one is connectivity and a backup plan. So it doesn't matter what program, what application, what system you're using. If you don't have a good connectivity and you have issues or interruptions, it's going to make the process for you and the patient very cumbersome and not very effective. So you need to have a backup plan. So even though we may have great connectivity, maybe we have storms come through and our backup generator or power supply is not working, have a backup plan to how can we still touch base with this patient. Maybe we can't do the video. Maybe we have to do some mainly audio. Maybe some of the equipment's not working or getting connected. So have that kind of backup plan. So again, you want to test your equipment as well. Take the time to experiment, practice with whatever platform you're using. Always make sure no matter if you have the same equipment, you're replacing it with another piece of the same equipment. You have a new equipment, you've just done an update on a piece of equipment. Always practice with the equipment you have. Make sure everything is still working and talking together like it should. Again, as a provider doing the telemedicine, know where to get technical assistance. Whether that, and we'll talk about a little bit in a little bit about your implementation and maybe your workflow, but know where to get technical assistance. Do you have someone there that is running kind of a telemedicine coordinator that will be kind of on site or making sure everything gets kicked off well on your side? If not, have the number for tech support nearby. Make a test run multiple times prior to you've done any new site. So if you expand, you have multiple sites. Again, before you just expand, make sure you've run through every piece of equipment and tested many times. Obtain contact information for all your remote sites, again, ahead of time, a direct phone or mobile number. Again, maybe everything's working on our side, but not their side. They can't see or hear you. Having a direct line, so again, you can call them directly and maybe work around the problem or troubleshoot it that way. Adjust the camera so that you feel the screen as much as possible instead of also seeing your desk, chair, walls, whatever you may have. So again, you want to have just kind of your shoulders, maybe your upper torso and your head fully in frame in the video. Have a trained person even at the remote site, someone there. Again, part of your workflow process of they're responsible for turning on the equipment, shutting it down. Telepresenters can be trained very easily on equipment and the technology, the software these days. And again, have them check the equipment 15 to 30 minutes before each session, just to make sure things are working and ready to go. Also, typically you might have a waiting room. So when the patient comes in, they're coming into a waiting room. Have this waiting room, a virtual waiting room where they are greeted by either someone from your front desk or, again, maybe you have a specific telemedicine coordinator who is making sure the patient has come in, they're greeted, welcomed, and they're kind of given an update of maybe the provider's running behind or they'll be right there, et cetera. And make sure the waiting room is appropriate. The virtual waiting room, with a background or a screen saver or something that has, your logo or maybe some kind of marketing material on there. When you come in as a provider, again, make introductions. Just like you're alive in person, you'd come in and introduce yourself, and the patient will introduce themselves as well. You want to make eye contact, so that means looking into the camera. A lot of people will look at the monitor itself, the provider might, but you're from the other side of things. That means you're actually looking lower and you're not looking into the camera, which would be looking directly into the eyes of the patient. So make sure you look into the camera itself. You want to have a professional environment. You don't want to do it somewhere where it's sloppy or there's a lot of background noise or people coming in and out, et cetera. You want to have a professional environment. Either have a solid background wall, maybe your logo on that, or have a virtual background, again, with some kind of a logo. The virtual background, you have to be careful those can get glitchy sometimes, depending on even like the color of your chair when you go to move or what you're wearing. Sometimes it can make the background kind of flutter a little bit. So you do want to be a little bit careful with that. And as for you as a provider, wear solid or neutral colors. Avoid fluorescent lights, something very bright. You don't want to have kind of detail pattern, anything that will really kind of want to break up or get fuzzy on the screen. Again, keep things non-distracting, any kind of major jewelry, grooming items, etc. And again, make sure you look at yourself in a mirror and make sure you're appropriate and ready to go before you get on camera. We talked about keep your site clean, free of visual and auditory clutter. Really turn off any kind of potential noise, distractions, cell phones, pagers, PA systems, even your paperwork. It's amazing what microphones will pick up. If you're at your desk or your video room and you're flipping through paperwork, that can really be picked up and can be very distracting to the patient, or really it can even override your voice so the patient has a hard time listening to you. Be sure to use natural gestures when you speak and avoid too much movement. Again, kind of pay attention to your video as well and see what you look like. Make sure you're not moving and therefore part of your head's out of the screen, or you've moved over to the side and you only see half of you. Things like that. Smile, talk slowly to the camera, not your reflection in the monitor. It's safe to say, don't doodle, yawn, or chew gum. The patient's going to be spending all that time staring right back at you, probably even more so than if you're face-to-face in a brick-and-mortar location where they might be looking at something on the wall or even down the floor or their hands. They're going to be looking directly at you on the video. So again, like we talked about, introducing yourself, what facility you're with and how you're connected. And the telepresenter, they probably will introduce everyone in the room on and off the camera and just make sure things are running smoothly. Let's see. We talked about even dressing professionally. So dress as you would if someone's going to come into your brick and mortar location. If you wear a white coat, great, you wear that. Maybe have your logo on there. If you dress in a suit and tie, that's your attire normally. Dress that way in your video appointments as well. And always, look for and use nonverbal cues. So pay really attention to the patient when you are talking to them. Look for those little clues of maybe you're telling them or giving them some information and you see them kind of furrow their brow, or they have a quizzical look on their face, or maybe they're shifting in their chair a lot. Maybe they're getting bored, or they don't, maybe they're not understanding what you're saying. So look for those clues and adjust the way you need to so they understand. Focus on patient. Again, no distractions. In this session appropriately. Don't just kind of quickly wrap it up and click the end button. Wrap it up as you normally would, asking for any questions, follow up, kind of summarize what may need to be done, and go from there. So some technology trends, kind of shifting gears here a little bit. Really the basic items needed to start telehealth visits really are software. What kind of a software or video conferencing system are you going to have to be able to see and hear that patient? Hardware, what kind of computer or mobile device, microphone and camera are you going to use to be able to reach out to that patient? And then your internet connection or broadband. What are you going to have? That's really what you need to have minimum to get things started. So some of the trends really these days are web or linked based, no download. So you don't want the patient to have to go out to the web, download something, username, password, just to sign in to get in to see the provider. So with web or linked based, a lot of these are generated from the provider when the appointment is made, and an email it may be sent out to that patient that has a link in it, and all the patient would have to do would be to click on that link, and perhaps they have a password they've been provided with. They get into a waiting room, etc., and they're in the telemedicine visit. Or even web-based, where they're going out to a website again, and putting in some specific information, unique ID, and getting on there without having to download anything. You do want to, mobile platforms, we kind of touched base on that a little bit earlier. Mobile platforms are becoming the trend. Again, everything, mobile, not sedentary in one spot. You want to make sure whatever you do have, the deployability of that system. You could have the best system in the world, and does everything you want, but if you can't deploy it out and get it working correctly and routinely, then it's not really effective. Scalability as well. Always kind of think past what you currently are doing. So if you maybe have one or two remote locations that you're wanting to do telemedicine visits with, but yet you may expand out to 5 or 10. Well, whatever system you're using now, are you able to, easily scale that so you can take on either more visits, more patients, or more remote locations? And then the last two, reliability and ease of use. Really, the best, most robust system in the world. If it's not reliable and easy to use, provider will not want to use it. The patient will not want to use it. Maybe your telemedicine visit goes great, but then if it's hard to use, the patient ends up having a bad feeling or no satisfaction out of that visit. So again, make sure it's easy to use for both sides. A solo or small group practice can still conduct telemedicine visits utilizing the same version of technology as a large hospital system, just on a smaller scale. A good telemedicine visit, like we kind of talked about in the scalability, will allow for peripherals to be added later. So you don't want to get something where you're locked in, where you cannot add an otoscope, stethoscope, dermoscope, anything like that at a later time if you don't initially use that. A telemedicine cart is also a great option. Really, that kind of incorporates all of your hardware and software into a rolling movable unit. The cart can easily be moved to multiple rooms or areas. So if you had maybe a clinic and you didn't have one specific area that you used for a video room, a cart could be taken to maybe whichever patient was going to be using telemedicine that day. This is just kind of some pics of some of the peripherals that are out there. Electronic stethoscopes that are actually Bluetooth. So again, it's just amazing to me. You can hold that on a patient 300 miles away, and the physician provider, back in their office can hear the breath sounds and see the graph and chart those. Digital iriscopes, digital EKG, blood pressure monitors. A lot of these, even at-home devices, you can get these and use them off of your iPhone, and they're pretty reliable. So again, kind of with the technology, what's important is you want to make sure you're able to connect and then stay connected and download and upload everything. So bandwidth is really your internet speed, or the speed of your internet connection. It's how much data that can be received and sent between your device and the internet per second. So bandwidth is measured both as an upload, or up and down, or as a download. These speeds are not always the same. So you may be able to upload something much quicker than you're downloading. The minimal amount of bandwidth needed is usually determined by the conferencing software that you use. Here I have on the screen kind of what FCC recommends. This may be a little bit old data. It's probably going to be a little bit faster now, but as in anything, if you get more intense graphics or larger files or videos or pictures, you're going to need more speed to get those across. It's also a good idea to test your bandwidth at different times of the day, as the speeds may change based on the number of devices being used, the number of users accessing the internet, etc. You may get into your clinic at 7 in the morning and check your speed, and it's 100 Mbps. But then at 9 o'clock, when you have your staff there, they're on the system. They're accessing, the EHR. The other part of staff may be on their break, and they're accessing the internet via the wireless, etc. That really can affect your speed. www.fast, telemedicine.com is a great free service to test your internet speed. So we just type that in a browser, and it will actually just automatically read and tell you what your internet speed is. So very interesting. Always, again, kind of check that multiple times through the day, especially as you're leading up to implementing your process or your workflow. Maybe you found in the afternoon you're consistently slower, so maybe you want to move your telemedicine visits to earlier in the morning. Most reliable, of course, also would be hardwiring. Wi-Fi devices are fantastic. It allows you to really be mobile, but a hardwired directly to a modem or a port, a jack, etc., definitely going to be more reliable. Won't have the fluctuations that you might have, in which could cause some issues with your speed, image, or quality. I mentioned a telemedicine card earlier. Again, those are mobile, so really those can kind of be the best of both worlds. They can be wireless capable as well, but they still can have a hardwire ability. So maybe you move them into a room and it has an active port or jack. You're able to plug it in and still be hardwired directly in, but you're still able to be mobile with the cart. This is a picture of Mercy Virtual. So just to kind of the spectrum of telemedicine, telehealth, you can literally sign up and use a Zoom, a business user agreement version of Zoom and maybe an EHR that you have. You can use that and go bare bones and do a telemedicine visit. This is kind of the other end of the spectrum. It's the first of its kind. Again, Mercy Virtual Care Center. It began operating in October 2015 without a single patient in this building. The virtual care is delivered using highly sensitive two-way cameras, online-enabled instruments, and real-time vital signs, allowing the clinicians to, quote-unquote, see patients. Patients may be in one of Mercy's traditional hospitals, a doctor's office, or in some cases the patient's own home. So, this is kind of maybe whether we like it or not, this may be the way things are going. But this is how far we can take telemedicine right now. So kind of shifting gears again, some legal and privacy issues. Reimbursement, that's kind of a legal issue of and just a paying issue. We don't necessarily, it depends on where you're at. In Oklahoma, we do not necessarily have we have billing parity, so telemedicine visits can be billed the same as an in-person, but reimbursement on the payment parity is not guaranteed, unfortunately. So right now, also kind of remember that with the CARES Act and COVID, which we'll talk about shortly, that has changed a lot of this. But prior to COVID, not all telemedicine visits were reimbursed, and not all of them were reimbursed at the same amount as an in-person. You still have your credentialing and privileging issues. It seems like maybe you can get farther away, or you want to go across state lines. It's easier to do with telemedicine, telehealth, but you still need to be credentialed in the state, have privileges at whatever hospital, etc. Support personnel. You're going to have, this kind of goes along with that, the bottom one there, privacy, fraud, and abuse. You're going to have more personnel needed to again, support the technology and to get this platform going. So with that becomes, again, more kind of entry points of potential fraud or abuse or privacy. Licensure issues, compact. A compact state, if your primary residence is in a compact state, you do have a multi-state license. If your privacy or primary residence is in a non-compact state, again, it means you have a single state license. So all those things are still the same with telemedicine. You still have your confidentiality and HIPAA issues. It can be a challenge sometimes, as mobile as we are. Is the patient where they're at? Are they truly in a secure location that no one else would be able to hear or get their private health information? Maybe they have a lot of family members at home. They don't have a private place they can go to. So these are some issues we need to keep in mind with telehealth and telemedicine. So some of the issues, we kind of gone over some of those, but lack of standards is one. We do not have a standard across the board standard for every aspect really of telehealth. So you have a lot of folks doing a lot of different things right now. The need for a technical support. So that is part of the need. If you have your office, you may need to have an additional employee on board for technical support. Potentially, you can repurpose someone in your office. Maybe they have half the time doing tech support and half the time their previous job. So again, remember, you do need the tech support because it is technology, it is electronics. Something will go wrong. Lack of available infrastructure. Some folks have everything already built out, have the broadband, the connection, they have the equipment already. Not everyone does. So if you don't have that, it can be expensive. If you go, depending on what you choose, it can be expensive to have a full service telehealth telemedicine program. Accreditation and regulatory requirements. Those are, of course, always going to be some kind of an issue. Just the limitations of telehealth telemedicine. It is a great alternative, but it is not a true face-to-face, hands-on, visit. So if it's something that you need to have that hands-on capability, maybe this is not the best choice for you. A lack of funding with COVID and kind of thrusting telemedicine into the spotlight, and everyone kind of jumping on the telemedicine bandwagon. Maybe that stream of funding wasn't there from the last fiscal year. So how can we get that funding and get what we need to so we can continue with patient care? The quality of service rendered. Again, it's like anything. If you go about it not 100%, you may have a little bit of a lower quality of service, or the patient may feel there's a lower quality of service. So it's why you need to do your best to make them feel that it is the same. They're getting the same services if they're in person. Again, reimbursement. We talked about that. Not everything is reimbursed at the same amount or reimbursed at all at this point. And a very, very major one, especially like here in Oklahoma and from rural areas, connectivity and or broadband. So I may be a perfect candidate for telemedicine, telehealth, but perhaps I live in a rural area and I don't have a good internet connection or any at all. So those are some issues. A lot of these are able to be overcome. A lot of these we just kind of have to work with and do what we can. So implementation readiness. So let's say you want to kind of move forward with a telemedicine, telehealth program. So some of the things to think about, what are the payment and policy guidelines specific to various telemedicine services? What do we, as an organization, what do you want to, accomplish? Are you wanting to do a service line that perhaps is not reimbursed at the same amount as what you would in a face-to-face? So how will that affect your overall strategy for your organization? What kind of policies do you need to put in place to start this new telemedicine service? Even how do we have the resources to begin a telemedicine program? And really, you need to have a champion. And this is a champion from your top, your leadership, your administration. It's also very important to have a champion from the clinical provider side. There's always going to be naysayers, anything new that you do. So having that champion that's really out there, pushing for it, speaking positively about it, just like any project, you need to have that champion to kind of keep everyone excited about it and that kind of positive feel. Equipment. There is a need for at least a minimum amount of equipment that we've talked about. So do you have to go whole hog and have a full spectrum? No, you do not. That would be something to determine where do we want to start, what service line do we want to start, and go from there. The staff. Your staff need to be on board. You also have to have the staff to again, be able to monitor, coordinate this new technology. Leadership, we talked about that, having them on board. The funding, you need to have funding to, again, for all the equipment and or staff needed. So again, some of the must-have readiness, you need to have a detailed program plan. Like any good project, protocols, guidelines, policies, workflow, who's going to do what, when, how does it work, backup plans, etc. A performance monitoring plan, not only from a provider, but also a patient satisfaction. Maybe you're doing surveys. Are the patients just not satisfied with what you're doing or how you're doing it? Benchmarks, go out there and measure yourself against others and see, how are we doing compared to our competitors. An engagement of providers. Again, you need to have the providers not just throw it out there, send out an email saying, hey, next Thursday we're starting our telemedicine program. You need to have them engaged from the start, get them on board as well. You need to have equipment purchased, installed, and tested. And I kind of come from an IT side of things, so I preach this a lot, but you need to have it installed and tested. Again, even if you're replacing Part A with another Part A, test it multiple times before you attempt to use. You need to have stable technology. Again, all the fanciest technology, but if it's not stable and usable every single time, it's not good technology. You need to have your operational processes finalized and communicated to your staff. So again, you need to have your staff hired and assigned, trained. Do you hire new staff? Do you, again, reassign some staff you already have? Are they been completely gone through the training for their new position? And do they fully understand how this fits into the organization? And then lastly, a complete system walkthrough and testing. Again, go through, test, make sure everything is, and not just talking about a connection, but we're talking about complete walkthrough with a quote unquote test patient. Does the email system work? Does the link work? Everything. Go through and get that tested. So some lessons learned after implementing telemedicine, telehealth programs. Again, provider engagement is key. We've talked about that. Having a champion, we've talked about that. It is still medicine. Don't forget that. You may be doing it from hundreds of miles away through a monitor, but it is still medicine. So focus on that, the medicine. The technology is just another tool. It's not to replace the medicine. It's not to replace the interaction. It's just a tool to allow you to interact with someone who is at a different site. Again, the equipment doesn't need to be the most expensive to be effective. What the equipment needs to do is work every single time, be easy to use, and meet your needs. Plan and practice for telehealth, telemedicine. Again, you can't just jump into it thinking, hey, we have a couple of cameras laying around. Let's try this out. Technology and program support. So again, having that support there from IT, whether it's your organization's IT or maybe your own departmental IT, have that there and have them on board. And remember, this whole telemedicine, telehealth implementation is a process. It's not a destination. So you're going to be doing this. It's constantly going ongoing process and review. You don't just start a telemedicine program and then that's it. You're done with it. Always go through and make sure you're improving or reviewing things. So the CARES Act, the Coronavirus Aid, Relief, and Economic Security Act, and CMS waivers in response to COVID-19 have caused a lot of changes in telehealth and telemedicine. So much so there's we would need much more time than we have to talk about them all. But just kind of on a very high level, it's had a broad expansion of telehealth policy and rules. There's been a blanket temporary modification and/or waiver of certain Medicare, Medicaid, and HIPAA requirements. We'll talk down below enforcement discretion for non-HIPAA compliant good faith actions. So, for example, in the past, FaceTime or Skype, that's not a HIPAA compliant secure connection. But during COVID and during the CARES Act, those applications can be used in good faith for a telemedicine, telehealth visit. The enforcement hasn't been removed. It's just been the discretion is there that nothing will be, enforced during this kind of period. Provision of telehealth services in the home, new and established patients. So prior, you could not do telehealth in your home. You could do remote patient monitoring, but not telemedicine in the home. You needed to be at a certain location. New and established patients. Again, prior, you had to be an established patient before you could implement telemedicine with that patient. Now you can actually be a new patient starting with telemedicine. Broad expansion of non-physician providers, removing barriers for, non-physicians to provide telemedicine, telehealth. waiving prior authorization requirements for a patient to start and do telemedicine, telehealth. Previously, prolonged audio-only communication was not allowed. Now it is if video is not available. Accelerated advanced payments. So they have accelerated, moved up payments for telemedicine, telehealth, so that, again, providers could continue providing medical. Increased telehealth grant programs, which has been fantastic. Opportunity to have some money out there to get some telehealth equipment and or programs up and running in underserved and rural locations. Reimbursement, this is very much kind of like the CARES Act. We could spend an entire day on reimbursement, but just kind of high level, Medicare fee-for-service rules are, of course, the same across the nation, but the Medicaid fee-for-service rules do differ by state, so you would always want to, again, refer to your state rules for Medicaid regarding reimbursement. Private commercial carriers, the private payer laws, again, vary by state, as well as parity laws vary by state. The website I have there at the bottom, Center for Connected Health Policy, it's a great website to go to look for telehealth policy in all states across the United States. So go there and you can find out some more information. But reimbursement, of course, that's very important. We need to have that reimbursement so we can continue doing the telehealth, telemedicine. So kind of just wrapping things up. Seema Verma is the administrator for CMS, and in a Becker's Hospital Review article earlier this year, she stated, quote, "I think the genie's out of the bottle on this one. I think it's fair to say that the advent of telehealth has been just completely accelerated, and it's taken the crisis to push us to a new frontier, but there's absolutely no going back," end quote. So I don't want to, speak for Seema, but, what I'm hearing, it looks like, again, we've kind of made some of these changes to telemedicine regulations, and now we're seeing that they do work and they are effective. We're not sure that what will go back to pre-COVID days and what will stay with this kind of new version of telemedicine and telehealth. But, it certainly looks like we may not go back certainly to the exact same as we had. So I think it's going to be better for telemedicine, telehealth going forward. So again, telehealth, telemedicine expected to change the way healthcare is delivered and create new roles for providers and other clinicians. The role of the healthcare consumer is also evolving with the various telehealth applications like direct-to-consumer, all the different education and remote patient monitoring options we have out there. And really, telehealth does offer a way to help seniors, underserved, and or the rural populations independent and stay in their own home. This is just a kind of a quick graph and map of the telehealth resource centers. As you can see, the HTRC in the middle, Heartland Telehealth Resource Center, Oklahoma, Missouri, and Kansas. That's where I'm part of and the representative for them for Oklahoma. So if you have any kind of question regarding any of those states, please feel free to contact me on that. If you have a question about another state, I do have kind of listed on here the different telehealth resource centers. If you can't find those, please feel free to give me contact me, and I can get you in touch with those as well. We do have the 12 different regional centers, and we have 2 national centers. And we have one that's just focused on technology, the telehealthtechnology.org. So if you do have something along those lines, we can get you specific to a technology expert. And here are just a couple of resources. Again, the Center for Connected Health Policy, HTRC, which we talked about, TAL, the Telehealth Alliance of Oklahoma. Again, that's I'm executive director of. It's also really more legislative focused. But if you have a telemedicine, telehealth question, feel free to visit those websites or contact me, the National Consortium of Telehealth Resource Centers, or even for education, the Project ECHO here at Oklahoma State University. Well, thank you very much. I am Tim Davis. Again, I very much appreciated it. Here's my information. Please feel free to email or call me if you have any questions, comments, concerns. And if it's something I can't help you with, I certainly will do my best to get you in where you need to be. Thank you very much.